I'm Dr. Setari. It is a great privilege and honor for me to be talking to Dr. Obaida Batal. This man has changed my life. 4 years ago, when an orthopedic surgeon told me that I have severe arthritis in my left thumb, and that if I don't get surgery soon, I will not be able to perform surgery, Dr. Batal made sure that that didn't happen. I did not have surgery, and today I am still able to perform surgery with essentially zero pain. When I would get up from a chair and fall because of facet syndrome, Dr. Batal made sure that my pain went to essentially zero in my spine, and now I get up and I'm athletic and I'm working out again without any issues. Dr. Batal, it's an honor and a pleasure for me to be here and to be talking to you. You're board certified in general surgery. You have a fellowship in interventional pain management, and you have a tremendous amount of credentials. I've actually worked with other doctors who do prolotherapy, with dextrose, with PRP. There's something about the way that you prepare your PRP and the way that you inject that is unparalleled as far as I'm concerned. Tell us about that.
Well, thank you for that introduction. I actually don't deserve it. And you're asking about what's different about it. I mean, I don't think I'm the only one who does it exactly this way, but the PRP has been well misunderstood by either the public or by the people who perform it. Again, everybody spends some blood, they extract some plasma and call it PRP. If they take 10 cc of blood, they spin it, they take 5 cc of that, and they call this PRP, which is okay. PRP stands for platelet-rich plasma. Any plasma that has some platelets, a bit richer than normal amount in the blood, we can consider this PRP. But in order for the PRP to work, you have to have the concentration of the platelet in it should be, at least in my opinion, and also based on the research, at least 7-fold and above. I tend to shoot for 10 folds and 20 folds, depend on the area.
And that means a lot of blood.
That means, yes.
Because I know you've drained me sometimes like a vampire.
Absolutely.
You're just taking giant volumes of blood from me, but that's how you get so much PRP that's necessary in order to inject all of the different areas for me that you need to inject.
Correct. So the minimal, I mean, depend on how much volume do you want. So you want 1 cc, like if you want 1 cc, then you can, like at least you need like 50 or 40 cc of blood to get this 1 cc or 2 cc's. But if you want to inject multiple areas, and I'm going to talk about the location of injection, that's actually of huge importance too. That's additional. Let's say, for example, if you want to inject the joint, you need 3 to 4 cc, but usually we don't only inject the joint, we inject some other areas.
So
and we can talk about
you
this.
just said for 1 cc of PRP, you draw how many cc's of blood?
Well, it's a calculation. Not all the people in the world have 400,000 platelet per ml. Some people have it 150, some people have it 250, or some people have 600. So there's a lot of variations. So in order we need to tend on the safe side. We need good amount of platelets. Not only platelets. I mean, we're shooting for platelets, but we're getting another byproducts in it too. A lot of surgeons, they do not want those byproducts. I want them. Which is, you know, the monocytes, the poly omega-sites, and all those. They come in the same zone with the PRP. They cause more inflammation, they cause more pain, but they are part of the orchestra that we need. The platelet alone, yes, the platelet is the first responder. Like if you have any wounds, the platelet arrive first. Because they're small, they're able to leak between the blood vessels. But they are the first responder, and they generate a growth factor that there's the second line and third lines. The white blood cell, the omega side, the monocytes, and the macrophages and all those. I want those in the juice. So although like we're focusing on the platelets, but we want the other factors because it's kind of a big construction site, and we need the engineers, and we need the people who kind of scrape the floor, and we need people to lift, you know, the weight. So the juice of the platelet-rich plasma, although the name platelet is in it, but for me I want all the pro-inflammatory sides.
Right.
And there's two kinds of PRP. There's leukocyte-rich PRP and the leukocyte-poor PRP, and there's differentiation in the literature. Like, if this concentrate has only platelet, or it has other reduced too. They are used for multiple, you know, if you're injecting around the eye, you do not want intense inflammation, so you only want platelets. But most of the body, in my opinion, needs the other factors too.
This is critical information. There are a lot of doctors doing this kind of stuff, and thank God they are.
Yes.
Because this is fantastic technology. It helps with healing, but you can see how even within this incredible advanced technology, there's a spectrum of doctors who have this advanced level of knowledge, you know, compared to doctors who just sort of like I've had doctors just take like 5, 10 cc's of blood, spin it down, and say, here's your PRP, and inject just 1 cc into my thumb. It hardly did anything. I know you've injected 3, 4, 5 cc's into my thumb. The next day, my hand was very swollen, and I was concerned, and I called you, and you said, oh, don't worry, it's just fluid, and it'll get better, and it did. And my pain went from 6, 7 out of 10 within about a week or two down to 0. It was miraculous. You know, and thank you.
Sure, yes.
And this is why I'm back. The last time you injected me was over 1.5 years ago, and right now, just sitting here, my pain is still 0. But
and
when
that's not easy to get in the thumb too.
Right? Yes, correct. It's such a small joint, and it's it's a joint you constantly use. It's not easy to get.
Yes.
When I'm doing surgery now for the last month or so, I do have some pain to about 2. And that's why I'm here to see you.
Yes.
Plus, I've been very athletic. I've been working out again. And in my back, I've noticed my muscles are getting stiff, and I'm getting some pain to about a 3. And that's why I'm back to get some more treatment. Yes. I like being at 0. I want to see if you can get me back to 0 again.
Yeah. Yes. Well, for example, the thumb, as I said, the location of injection is also of importance, because I cannot, even if I want, to inject 3 cc's of fluid into your thumb. I mean, the maximum amount to that metacarpopharyngeal joint of the thumb, there's multiple joints around it too. I cannot inject more than even 0.2, 0.3, because the joint doesn't tolerate, you know. But we inject around it too. We inject the capsule around it.
Yes.
We inject the tendons around it.
Yes.
And that's
important for arthritis.
Yes, because
we've discovered that with arthritis, it's not so much the cartilage in the joint that's being worn down, but it's the surrounding ligaments that have become lax and are allowing the joint to move in directions it's not supposed to move. So when you strengthen those ligaments with the prolotherapy, it actually helps slow down the progression of the arthritis.
Correct.
And reduce the pain, because now the joint has been fortified,
more stable. And sometimes
more stable, yes.
And sometimes those are the cause of pain. Those tendons and ligaments are the source of pain. They've been mistakenly been neglected, and because the arthritis are shown in the X-ray or the MRI, because the tendons sometimes you cannot be seen in the X-ray or CAT scan. You can see it sometimes in the MRI.
You think it's the loss of the cartilage, the joint
and everybody
space,
look at that.
But it has actually been the ligaments and the surrounding tendons that have been the problem.
That's why, like when we do an X-ray, we do X-rays or MRI. I have it. I enjoy having it in the part of the workup. But the minute I see it, I forget about it, because a lot of times this MRI, especially in the back or in the neck, it's actually showing me a lot of noise of reading. But what matters is the exam, you know, because let's say the joint, like somebody had normal joint in MRI, but he has severe pain, and you examine him, oh, you know where the pain is. It's this ligament or this tendon or this capsule. But the other person, he has severe bone on bone, and the joint is actually not causing the pain.
Right.
So in your case, maybe like, I do not want to talk about somebody who had severe spinal stenosis and severe disc bulges in every level, but the pain is not from that.
Right.
the
It's
pain
funny,
is from something else.
My
you know?
father was a doctor, and he used to teach for the SUNY school system in New York, and I remember sitting in on one of his lectures, and he said, 80% of your diagnosis is going to come from your patient's history.
Correct.
And I remember in medical school, myself being taught, treat the patient, not the test.
Correct.
And you're saying the test result is all good and fine, but it's the patient that matters. You're treating the patient, not the MRI, not the X-ray, and that's what matters.
And this is what we getting locked into, because the insurance company want documentation why the pain is happening, and you have to get those tests to justify the treatments. But a lot of time the image is pointing at something and the pain is something else.
Right.
Sometimes they correlate. I mean, I'm not saying
Right.
they're completely useless, but
As a
I see
doctor-
it, make sure there's no finding that will prohibit me from doing injection. Or sometimes I tell the patient, look, you still need surgery. I will do this as a kind of salvage attempts to treat you, but I still think you need surgery. And despite this, we get surgery aborted after that, because people who do surgeries for the spine, or they still need injections afterward, you know, like it's not like they get fixed.
Right, to accelerate the healing. I was just
Correct.
having this conversation with Eloise with the mesenchymal stem cells.
Or the surgery did not correct the actual thing that
Right,
caused pain,
right,
you know.
right.
They improve it, but it doesn't, because it's degenerative in nature.
Right.
Well, there's a lot of factors about pain that we started to unleash, because the pain could be influenced by the brain, the way you sleep, the way you eat, the inflammatory
microbiome,
molecules
the
of
gut
microbiomes.
bacteria
Absolutely,
can
yeah.
influence pain, we're discovering.
The diet, the junky diet that we eat, that's full of hormones, that
Right.
could create chronic inflammation generally.
Yes.
That will make the local inflammation worse. So we kind of pinpointing one area of the pain, but then if the pain is not rested, the brain is anxious, you will have more pain. So I think we're gonna, Dr. Setari, and hopefully we're gonna work to do comprehensive view of pain that start from hopefully the nutrition, into the localized injections, into the brain aspect. Because I tell everybody, like, the signals to the brain, we don't call it pain. Once it arrives to the brain decides if it's painful or not.
Right.
And if the brain is anxious, you'll have more pain.
Right. And this is the cutting edge concepts that are important, not the old 15, 20, 50-year-old concepts that are in the textbook that unfortunately a lot of physicians are still practicing.
Correct.
This is why I enjoy talking to experts like you that are on the cutting edge of the field. You know, you saved me from having to have surgery when I didn't need it, and I'm grateful to you for that. I'm Dr. Robert Setari. Thank you so much for joining me and Master Dr. Obaida Batal. Please, if you have chronic pain, seek out an expert in your area. Get tomorrow's treatment today.